Good evening, everyone. As you know, we are celebrating Breast Cancer Awareness Month. I am Dr. Nishant Sharma, and I welcome you back to another virtual episode, which is powered by Pfizer. Today, we talk with multiple specialists and we talk about the advances in breast cancer treatment. We'll talk about personalized medicine and targeted therapies. So without further ado, allow me to welcome all my panelists. We have with us Dr. Pankaj Goyal, consultant medical oncologist at Rajiv Gandhi Cancer Institute and Research Center, New Delhi. Good evening, Dr. Pankaj. Thank you for joining us.
Yeah, good evening.
We have with us, thank you, sir. We have Dr. Shyam Aggarwal, Chairman and Director, Department of Oncology at Sir Ganga Hospital, New Delhi. Good evening, Dr. Shyam.
Yeah, good evening.
Lovely seeing you, sir. We have Dr. Kripa Bajaj, Consultant Medical Oncology and Cancer Genetics Clinic, B Indo-American Cancer Hospital, Hyderabad. Good evening, ma'am. Thank you for joining.
Very good evening. Thanks for the opportunity.
Thank you. We have Dr. Vaibhav Choudhary, Consultant Medical Oncology at Kokilaben, Dhirubhai, Ambani Hospital and Medical Research Center, Mumbai. Good evening, Dr. Choudhary.
Good evening. Good evening.
And we have Dr. Chanchal Goswami, Senior Consultant Medical Oncology, AMRI Hospital, Kolkata. Good evening, doctor.
Yeah, good evening, everybody.
So to set the tone of this discussion and to set the idea of what we are talking, I'll start with a little bit chat about what is breast cancer, what are some common signs and symptoms. So I'll start with Dr. Shyam. Dr. Shyam, please set the tone of this discussion for everyone who has joined us in this panel and the viewers. What is breast cancer and what are some common signs and symptoms and clinical presentations that patients present with? Over to you, please. So you're on mute. You'll have to unmute yourself. Yeah.
I think people understand about cancer that it is an autonomous abnormal growth of cells which can arise from any part of the body, and they can then increase in size locally. And if you don't check it, it can go into the regional or the surrounding lymph nodes. For example, for breast, it will be the axilla. And then through the bloodstream over a period of time, the cancer cells can spread into the whole body. So breast cancer is the one which arises in the mammary gland, so it's a common cancer in women. It's number one now in our country. Almost 1.8 lakh new cases of breast cancer occur. And mammary gland also exists in men, and therefore breast cancer can happen in men as well, although the incidence is very small. So the common symptoms of breast cancer are that there is a lump which is usually painless, which gradually increases in size. And if the cancer is located near the skin of the breast, well, then there can be a tethering of the skin, and if it's located in the nipple area, then one can have, discharge, which can be a bloody discharge. And as I mentioned, the tumor cells then spread to the axilla, and people can come with the lumps in the armpit or even in the neck for that matter. And if somebody has advanced stage cancer, then bones, lung, liver are the common sites of spread, and patients can have bone pain or cough or low-grade fever and loss of appetite. So, any symptom which is persisting in the body of a person beyond 3 to 4 weeks is an alarm signal. And if somebody notices a change in the shape or the size of the breast, one should go to the local doctor, whether a gynecologist or a surgeon or a physician, and ask for appropriate tests. So I think that's in brief to begin with, and then we can take it forward.
Thank you, Dr. Shyam. We'll start with Dr. Pankaj. So as Dr. Shyam very nicely set the tone and introduction, let's talk about diagnosis and your focus on early diagnosis and what's the impact that it has in the overall outcome that we see of breast cancer as a disease. Please, Dr. Pankaj.
So early diagnosis is important. Stage 4, if we say, though we have improved survival more than 5 years present time with late therapies, but if we detect a patient at an early stage, say stage 1 and stage 2, then the curative intent is you can say that the patient will be cured and there will be no recurrence around 90 to 98% of chances if it's a stage 1 or stage 2 cancer. So if the disease is diagnosed at an earlier stage, number one, the treatment will be less, it will be limited, it will be might be just surgery, and the patient is free of cancer, or there might be some light chemotherapy which will be needed, or hormonal therapy. So early diagnosis is very important. Issue is that when there is some breast lump, should not be neglected and should not be taken off for some traditional medications and some you keep hiding that's you are having some issue in the breast. It should be discussed with the family. You should present it to the surgeon or a local doctor, whosoever who is qualified in detecting all these cancers. And if a test is done, please do not shy away from getting a biopsy done and a imaging done. So usual imaging which we advise is a mammogram, X-ray mammogram, at smaller centers in two-tier cities. Even an ultrasound breast is also good enough a modality to test. However, as we have advanced, we can go for further advanced tests if there are doubts like MR mammography, but that is usually not required. So it's a X-ray mammogram, physical examination by self and the clinician, and ultrasound also can suffice in a smaller two-tier cities, and biopsy is actually better than a FNAC. So when in doubt, please put an ET.
Right. Thank you, Dr. Goyal, for very nicely pointing out about the diagnosis and the early diagnosis, the importance it holds. Dr. Kripa, please introduce our audience about the treatment options that are available once that a person is diagnosed with breast cancer, please.
So once the patient got diagnosed with breast cancer, any cancer treatment is a trimodality treatment. It usually consists of chemotherapy, surgery, and radiation. Especially breast cancer, we try to introduce like chemotherapy, surgery, and radiation in sequential manner. Just like how the mankind like will have a tall, short, and all, breast cancer also will have a 4 types of cancers. As per the type of the breast cancer, we will offer certain types of treatment, like apart from the chemotherapy, the modulation of chemotherapy, addition of immunotherapy, plus or minus some targeted therapy will be there in the management of medications we use. And also apart from that, surgery not much different, and radiation the almost the similar kind of treatment will be given, but the kind of target therapy, the hormone therapy, what we use will depend on the type of cancer. Just now, Dr. Pankaj rightly mentioned, biopsy plays a very crucial role in the management of breast cancer, because by knowing the type of breast cancer, it's a predictive marker to select the treatment options for breast cancer. The whole prognosis and everything will change as per the type of the breast cancer.
Right. Thank you, Dr. Kripa, for mentioning that. Dr. Vaibhav, my next question will be for you. Now, coming over to the topic and the discussion, what are some advancements and innovations that are there in breast cancer treatment that have proven really effective? You explore and you want to educate the public about them, please.
Yeah. A lot of things have changed, first of all, and breast cancer is the cancer where actually the survival has improved quite a lot. Exceedingly well they have done, because as earlier speaker also said, that we are in a process of detecting it early. Now, what happens if you can't detect it early? If unfortunately cancer has become stage 4 or it is advanced, sometimes it actually spreads very rapidly. So most of the research or newer things which have come up in my field, especially I'm a medical oncologist, so is systemic therapy of cancer, breast cancer especially. So here it's a varied heterogeneous disease where we actually have a lot of things targeting depending upon the type of cancer. Like target hormone therapy has been working in breast cancer, we know, for decades now, and it does help a lot. On top of that, targeted therapies have made a forway in last 15 years. Target therapies actually have come up and they have improved the survival to an extent that it has added to whatever we were achieving by hormone therapy in hormone receptor positive cancers. There is a type of a cancer which is driven by a certain molecular marker, that is HER2, which used to be an aggressive cancer. Here targeted therapies have come, now dual target therapies have come, and new molecules, bioengineered molecules are coming in this horizon, which are increasing the survival even in stage 4. It is in the tune of years now. Firstly, as we know that stage 4 cancer is not a good disease, and the survival were in months earlier, maybe 2 decades back. Now, since past 20 years of research in genetics, genomics, personalized therapy, target therapy, we have actually able to improve this survival. Next one, the block is immunotherapy. Yet, immunotherapy, there are not many indications in breast cancer, but a certain variety of breast cancer actually do respond very well to immunotherapy, and they also do have durable responses. But it is a very, very small proportion right now. So, as of now, hormone therapy, target therapy, immunotherapy are the newer things, but the basic core is low dose of chemotherapy, which eventually helps the patient. And newer progresses, newer advances are always there. Every 6 months to 1 year, we are getting newer drugs in this horizon. So it is a very active field.
Right. Thank you, Dr. Vaibhav, for pointing that out. Dr. Chanchal, my next question will be for you. First of all, anything that you would like to add to everything that has been discussed? And one last pointer while we move towards the actual topic is some common myths, misconceptions, misinformations that you have seen as a practitioner that you'd like to bust through this breast cancer awareness campaign that we are running, please.
Well, first of all, I think all the speakers have elucidated so nicely that everything has been said. As far as what Vaibhav has said, the new thing in chemotherapy, apart from immunotherapy, is the drug conjugates, which has come in a big way in breast cancer management, and the targeted therapies in hormonal therapy. Earlier, we used to do only hormonal management. Now we are adding CDK4/6 inhibitors, PIK3 kinase inhibitors. These are also an added armamentarium. As far as the myths are concerned, the entire cancer treatment in India is full of myths. It starts with don't do a biopsy, cancer is painful, all cancer is painful death. So it's full of myths. And there are Babas and there are other pathies all enjoying the role of homeopathics. So I think cancer treatment is full of myth and we have to fight it a long way to get it free of these myths. But the major myths is that cancer is infectious disease. It is not. Cancer doesn't spread with biopsy. Cancer not necessarily means painful. Cancer doesn't mean always death. So these are the biggest myths. And cancer doesn't always run in the family. So these are the major myths which we have to deal with. And I think awareness by both print and electronic media and we professionals are continuously engaged in awareness. And I don't know, I think we will continue to do so till the end of our life. And I think still our population will not become aware of cancer.
So we can do what we can, but I appreciate the good effort and thank you for every all of your time for spending with Voice of Healthcare in the campaign that we are running around breast cancer awareness, and thank you Pfizer for obviously powering all of this. So moving over to the topic, Dr. Pankaj, I'll start the topic with you. My next question will be: what is genetic testing for breast cancer and how does it work? Let's educate, please.
So genetic testing, there are certain indications when to do this genetic testing. So like if we are having a patient with breast cancer, we have to see if the patient is quite young, say less than 45 years of age, or the patient, if the receptor type is triple negative, then even at till age of 65 years, we do suspect that it might be hereditary. And if the patient's having cancer in both the breast, or the patient's having two cancers, breast cancer and ovary cancer, or the patient's having a strong family history, first degree relations, or multiple patients with breast cancer or ovarian cancer in the family. So in all these patients, we suspect that the possibly patient may be having a hereditary breast cancer. So out of whatever patients we find, only 5 to 10%, 5% of the patients will have significant family history. But if we have suspicion on the basis of whatever factors I have enumerated, and we test this patient, maybe 20 to 25% of the patient will turn out to be positive for the test. What we usually do is the BRCA, BRCA test. So we do this. This can be done from the oral mucosal tissue and also from the blood. So if we do this test, then positivity or negative can have implications not only on the treatment of the patient as far as maybe some tablets which will be prescribed later on. Even the surgical approach might differ. We may go for a complete removal of breast, or we may go for a prophylactic removal of the other breast also. And at a later date, if the BRC is possible, these patients also need some surgical procedures like prophylactic salpingo-oophorectomy. And also, this will have implications in the families, because all the first degree relations, especially the females, the daughters, the sisters, they need to be tested because there are high chances that they will be positive. So you have so many implications with BRCA, and again, that implication not on just the patient but also the first degree relationships, especially the females, and also the follow up of these patients is quite different, because unlike any other patient, garden variety patient who needs a mammogram possibly a year on follow up, if the patient turns to be BRCA positive, then possibly we have to give emphasis that we screen the breast every 6 months, maybe with the MRI in a year and mammogram alternate. So that is the importance of BRCA test. And I think this came into picture with the Angelina Jolie actually, who reported that she had BRCA positive and she underwent this prophylactic breast surgery and prophylactic salpingo-hysterectomy. After that, the acceptance of this test and all these prophylactic surgeries, the acceptance has really increased.
Thank you, Dr. Pankaj. That was a very nicely summed up answer. Dr. Shyam, in your sense, how do you feel genetic help doctors choose the best treatment modality for a person's specific type of breast cancer? Please.
Nishant, before I have limited time because, I have to leave by 7. So I just wanted to clarify a couple of new things before I answer your question.
All right.
So,
Please.
there is a little paradigm shift which patients should know, and which is what we are doing. When a patient has breast cancer, first of all, she should know whether we are dealing with early breast cancer, which is potentially curable, or she is dealing with metastatic breast cancer, which is possibly not curable, but you can convert it into a chronic disease. Number one. Number two, she should also understand by way of these tests whether she has hormone receptor positive cancer, or a triple negative cancer, or HER2 positive cancer. So there are 3 types based on estrogen receptor, progesterone receptor, and HER2 testing. So, these 2 things, early versus metastatic, or these 3 types of breast cancer, would have different treatment options and different outcomes, which the patient and family must be explained. Now, coming to the paradigm shift in early breast cancer.
Right.
You see, until about 5 years ago, if a lady had 2, 3, 4 years, 4 centimeter tumor, which is confined to the breast, we were talking about surgery, which could either be a modified radical mastectomy or a conservation surgery, depending upon the size of the tumor. But now, in the last 2, 3 years, if a woman has triple negative breast cancer or HER2 positive breast cancer, then we are not talking of upfront surgery. We are talking of induction treatment, neoadjuvant treatment, chemotherapy, so as to reduce the tumor size and then perform the surgery 6 months down the line. So that is a huge paradigm shift which has happened in the last 2 years. So, women come to us, patients come to us, sir, ये 3 centimeter का tumor है, इसको निकाल दीजिए. So we actually, with the surgeons in majority of the cancer hospitals have accepted this paradigm shift, that even in tumors which are more than 2 centimeters, we should not perform surgery upfront. We should subject them to chemotherapy for about 6 months or 4.5 months, and then perform the surgery, which could either be breast conserving surgery or it could still be a modified radical mastectomy. So, that's a very important paradigm shift as early breast cancers are being diagnosed. So now coming to the genetic, part of the cancer, no, BRCA1/2 is positive in about 5 to 10% of patients with breast cancer, and as Dr. Pankaj alluded to, it has a bearing on the screening and the prophylactic surgeries. But of late, in patients who have early breast cancer, these patients who are BRCA1 or 2 positive can be offered a drug which is called olaparib, which is a PARP inhibitor, along with the hormonal therapy if somebody is HR positive, or with the chemotherapy. So it has not only got a bearing on the prophylaxis part or screening part, it also has a bearing on the treatment part. Similarly, if somebody has metastatic breast cancer and you do the genetic testing and the patient is BRCA1/2 positive, the same drug, PARP inhibitor olaparib, can be used in the treatment part of this particular individual. So, so that is about the BRCA1/2. Now, and which is, the genetic test or hereditary test. So there is another type of test which has become available for somatic testing. These are all technical words which the patients have to understand, that you take the tumor and send it for next generation sequencing. So the point is that you are looking for some gene alterations which could be druggable. But the problem is that only about 5% of patients will have a somatic mutation which can be drugged. So, you have to explain to the family and to the patient that the gene testing is available in various fashions. I think Dr. Chanchal said PIK3C testing is there in about positive in 40% of hormone receptor positive. So that is also routinely being done. So, the point the family or the patient has to understand, that cancer is a genetic disease, but it is not hereditary. Hereditary is only in 5%. So 95% of the breast cancers are acquired by the patient during their lifetime because of the changes in the genes in the mammary cells or in the breast cells. So, these are very technical things which, is very difficult to explain in, 2 minutes or 4 minutes. But then the families have to understand the importance of hereditary breast cancer, BRCA1, 2, PIK3C gene, and the next generation sequencing for somatic testing.
Thank you, Dr. Shyam. Very, very nicely educated and inspired answer. Thank you. Dr. Kripa, my next question will be for you. Moving over to more therapeutic areas, what is immunotherapy, and how do you feel it helps, and how does it actually differ from the traditional chemotherapy that one of our panelists had already mentioned? Please.
So immunotherapy is the latest advance what we are seeing in the treatment of cancer. Like it's really a path-breaking drug, I would say. In the breast cancer, though it's a limited, as we suggested before, the previous speakers also alluded to, the breast cancer is a heterogeneous one. It consists of 3 types of cancers. The role of immunotherapy is certainly there in triple negative breast cancer, be it early breast cancer or metastatic breast cancer. Introduction of immunotherapy in triple negative breast cancer will lead to a good response rates and outcome. So chemotherapy is different. Chemotherapy is a drug which will act on the fast dividing cells. It's a drug which we are introducing. The drug itself will act on the cancer cells. Immunotherapy is a new area where the immunotherapy will awaken the own immune system of a person and will make the immune system to attack on the cancer cell. This is a new era of treatment modality in the oncology. So all organs of cancers got affected with the immunotherapy. In breast cancer, though it's a limited role, but in the triple negative breast cancer, the impact of addition of immunotherapy to the chemotherapy, the outcome will enhance, be it early cancer or metastatic breast cancer. The targeted therapy is different, chemotherapy is different. These two cells, the drugs per se, will act on the cancer cell, but immunotherapy will awakens one patient's immune system to attack on the cancer cells. So there is a difference is there, and this a long-lasting effect will be there on the patient cancer cells. Once the immunity is awakened, it will be awakened forever, and it will try to fight on the cancer cell.
Right. Thank you, Dr. Kripa, for mentioning about immunotherapy. My next question will be for Dr. Vaibhav, talking about the roles that hormones play in breast cancer, and please discuss about hormone therapy.
Yeah, hormones, obviously, majority of the breast cancer, 65-70% of the breast cancer is estrogen receptor positive, progesterone receptor positive most of the times. And it is a routine case. The maximum bulk of the disease, as breast cancer is the commonest disease in the world. This is the estrogen receptor positive is the biggest share, more than around 70%. So yes, we need to address this. This is because of the hormonal changes which take place inside in the breast cells and in the body of a female. The biggest risk factor, commonest risk factor for breast cancer is being female. Yeah, as Dr. Shyam also suggested that male breast cancer is also there, but it is quite rare as compared to female. That is the biggest risk factor. That is because of these hormones only. These female hormones actually, whenever there is alteration in them, there is some perturbation. It actually leads to proliferation, and because of the proliferation of the growth, unregulated growth, these tumors are formed. The second biggest risk factor is actually age. It is a disease of aging. All the cancers actually increase in incidence with age. Hormone receptor positive breast cancers are like that. They mostly present late. It's very rare to find early breast cancer, early and younger patients with hormone receptor positive. They are mostly triple negative or HER2 positive. So there is a subset of ER positive as well in BRCA mutated patients. So hormones basically it has two aspects. One, because of the hormonal perturbations, these things are formed. So that those receptors are there which are found out in the biopsy of this tissue of this breast cancer patients. We specifically look for estrogen receptor, progesterone receptor, and there is a receptor which is HER2. So, if these receptors are positive, estrogen and progesterone, and HER2 is negative, then that patient is very, very likely to respond to hormone therapies. Hormone therapies just block the effect of these hormones. There are some different lines of hormone therapies which are there. They are being extensively used after surgery as an adjuvant, as well as in metastatic stage 4 setting, also along with targeted therapy. So these are simple drugs to take. Most of them are oral drugs. They have very less side effect because they, unlike chemotherapy, they will not harm the body that much. They will not cause that degree of side effect. And basically, what it is basically a target therapy only. So then, when you combine that hormone therapy with another target therapy, you get exceedingly good results. So the story of breast cancer has actually changed completely since we found out that yes, most of these are receptor positive, hormone receptor positive, and we have actually since I think 5 decades we are using estrogen therapy, anti-estrogen therapy in breast cancer in various settings. Now the role is more and more defined, and we are getting even better drugs, even better hormone therapy drugs. Where what happens is cancer cells actually they change their nature. Once we attack them through a certain hormone therapy, then maybe 6 months, 1 year, 2 year, they change their structure and then they become resistant. So to target that resistance, actually we have to then study the nature of the tumor and maybe give second line of hormone therapy, third line of hormone therapy, combined with target therapy, intersperse this thing with some sort of a chemotherapy when it has become absolutely refractory. So that's why hormone therapy has the biggest role in the breast cancer as of now.
Thank you, Dr. Vaibhav. So with this, Dr. Chanchal, my next question to you will, we have discussed about the different therapies available. How do you feel and how is it important that different types of doctors, surgeons, oncologists, radiologists work together in treating breast cancer patients, and how do you see the change in there? Please.
Well, as you have heard so many varieties of treatment being implemented for breast cancer, starting with surgery, which is the oldest form of therapy. Apart from them, we haven't talked much about radiation, but radiation therapy. Then, of course, the systemic therapy, which includes chemotherapy, hormone therapy, immunotherapy, targeted therapy, so on and so forth. Other than that, you have the pathologist, the radiologist, uh, the breast cancer nurses, the caregivers, everybody into this gamut of breast cancer treatment. And to decide which particular patient gets which type of treatment and in what combination, in what permutation combination, I think the most important thing is to have a multidisciplinary team. So when you diagnose the patient, whoever diagnoses the patient, before the patient starts treatment, all these stakeholders need to sit together in a multidisciplinary team meeting, which is called MDT, which will essentially have a surgeon, a radiation oncologist, a medical oncologist, maybe a pathologist, maybe an occupational therapist, maybe a radiologist, and finally take the call. Because the treatment decision, whether, as Dr. Shyam was talking, that if the tumor is 2 centimeter or more than that, we do not do surgery upfront. We do neoadjuvant treatment. So these are the decisions which are taken in the multidisciplinary team, and all tertiary care cancer hospitals do have these multidisciplinary teams where all these specialties get together and decide on the treatment. Maybe this is not possible in smaller centers or other centers, but I think people who are being treated in smaller centers or clinicians who are working in smaller centers, instead of having a multidisciplinary team, can have discussion among the other clinicians and get into a formation and protocolize the treatment, thereby giving the best. And it is always understood, and it has been found, and it has been proved in clinical trials, that patients who are treated by multidisciplinary team has the best outcome. So I think that's the way forward as far, and this is not only true for breast cancer, that is true for all cancers, to say the least.
Thank you, Dr. Chanchal, for answering that question. Dr. Pankaj, as we move towards patient education, patient awareness, through the medium of this particular episode, how can someone learn about an ongoing clinical trial for breast cancer treatment and can potentially participate if they're interested? Please educate our audience for that.
So I think most of the tertiary centers have access to these trials. So if someone is interested in a trial, he or she should inquire in the nearby tertiary care institutes. And important is that most of the patients are in this misconception that the trial which we are running in a tertiary institute is some sort of experiment which is done on the guinea pigs. So they are always afraid that they think they hear about trial and they just go berserk that some experiment is being done, and he just gets suspicious that what's happening. So it's important to understand that if a trial has gained access to a tertiary institute, the drug or whatever the thing is under the trial has been tested prior to that several times and in actual human patients, rather than thinking that this is some guinea pig experiment. Because I always try to explain to the patient that if someone is running a trial in different countries in so many institutes, then he or she is investing, whatever company is investing, billions of dollars. So if they are not sure that this will work, this much of investment will not come in that particular segment. And most of the drugs which we are using, the current drugs, if you talk about the pertuzumab, you talk about the PD-L1 inhibitors, these were once free of cost being offered in a trial. So the patients who had enrolled, even now they are getting those costly drugs free of cost. So this is the latest drugs which are available, which will become standard of care in coming times. So no one should shy away from participating in a clinical trial.
Thank you,
These
Dr.
all are
Pankaj.
phase 2 or phase 3 trials.
Right. Thank you for educating our public. Dr. Kripa, in the continuation of education, according to recent researches, what are some factors that increase or decrease the risk of developing breast cancer?
So the we all know, like from ages, like it has been discussed, it's been displayed everywhere that usually there is a good component like 5 to 10%. Like people have already discussed regarding the hereditary predisposition. Apart from that, the breast cancer majority the will be affecting the females. Whoever conceived late with the early menarche means early menstruation, who bore a child in the delayed age, who has no lactation or significantly less lactation, and whoever not conceived at all, these kind of people will have predisposition to the breast cancer in general. Means you are having a significant estrogen levels in the body without any discontinuation because of pregnancy, lactation, and all this. Apart from that, lifestyle factors have a significant impact on the breast cancer. There is an alarming rise of breast cancer in the urban areas, especially Mumbai. Like there is a significant peak of breast cancer is there across the India. So if you see that the reason is mainly the lifestyle, because of the increased fat intake, there can be hormonal imbalance which can predispose to the breast cancer. So and good exercise, these can prevent the breast cancer, and good food with its with lot of greens and vegetables that also in general have an impact on the prevention of the cancer. So these things have predisposed the rampant increase in the recent onset breast cancer epidemic, I would say, in urban areas.
Thank you, Dr. Kripa. Dr. Vaibhav, my next question will be for you. Any notable regional variations in breast cancer that you have seen, or maybe socio-economic variations in breast cancer? This is kind of a different question, but any variation according to your practice that you have seen in patients between a rural area and an urban area, and maybe of people different socio-economic zones? Any regional variations? If you have some yeah, you're on mute, sir. If you can maybe.
Yeah, so obviously, yes, there are differences. I happen to see a wide variety of patients coming from different socioeconomic backgrounds as well as different cultures. So, what happens is typically in the lower socioeconomic status, most of these lumps and all, they are ignored till they cause pain, till they become infected, till they become really advanced, and patient starts having a lot of suffering because of it. So that's an advanced stage. So most of those patients actually have a stage 3 or stage 4 cancer to start with, and their prognosis is actually bad, because then we have limited options at that moment. As compared to that, in metro cities like Mumbai, Delhi, or aware population, even in B town, C town as well, the educated people, they actually present early. There are certain areas where actually this guideline of mammography yearly after the age of 45 years is being practiced, and there actually we find very early stage, sometimes so early that then patient can actually get away with surgery alone, and without even chemotherapy and radiation therapy. So that is a difference in, as the India is a very heterogeneous country, there are different areas, different population, different belief systems. Similarly is the story with breast cancer found in India. It's like we see a spectrum from the very early patient, mostly in educated patients, aware patients, to a very locally advanced patient, very advanced patient in uneducated population as well as lower social status. So actually, it has become very challenging for us to treat more advanced diseases as compared to the early diseases. So awareness is of paramount importance to find out. As the previous speaker also said that yeah, most of these breast lumps are painless. It's not like that you have to wait till it starts paining, because till the time it starts paining, it becomes locally advanced. It becomes very advanced and difficult to treat. Right.
Right. Thank you, Dr. Vaibhav, for very nicely answering that. Dr. Pankaj, now as we were talking about therapies, what is personalized medicine in context of breast cancer, and what is the general difference that a layman should know?
So, breast cancer is not one disease. It comprises of different types of diseases, you should say. So, broadly, if we talk, then you can roughly say it can be either hormone positive, it can be HER2 positive, or it can be triple negative. Now, in each of these segments, you have different type of drugs, different type of approach. So, you have a tailored therapy. If you have say 50 patients, maybe all these 50 patients some might maybe having some different type of treatment approach and different type of treatment medicines what they are getting, and different sequencing of the surgery and radiation. So that is the personalized medicine, that every patient will have a tailored treatment for that particular patient depending on the receptor status, depending upon stage, depending on the performance status, depending upon accessibility to care, depending upon affordability. So like if you see, we talk about hormone positive subgroup. These are favorable. If they are early stage, then they get operated directly. If they are having metastatic disease, we have specific drugs, tablets which we use, like CDK4/6 inhibitors, which are used in combination with some hormones. If you talk about triple negative, now lately we are having this immunotherapy, which previous speaker has also elaborated that we use immunotherapy before surgery, or in the stage 4 also we can use immunotherapy, which can improve the outcome of these patients. If you talk about HER2 positive, we have plethora of drugs in that case, and apart from that, older drugs, trastuzumab, then we had this pertuzumab, we had the TDM1. Lately, we are having this TDS2. So every patient will have different type of approach, the way we are going to operate, the way we are going to treat these patients. So that is what we mean by the personalized therapy.
Thank you, Dr. Pankaj. Dr. Kripa, my next question will be in continuation to the previous answer. What are some primary genetic and molecular factors considered in curating a personalized treatment plan for breast cancer? Please.
So, as like already my previous speakers alluded to, breast cancer, the main thing what we see was the biopsy, that a bit of tissue will be removed from the lump and we analyze it for the type of the cancer. We call it a predictive factor. So, as I told you before, also we see what kind of breast cancer it is, ER, PR, HER2. We do see it's a early breast cancer. We do see like what extent we can use the chemotherapy targeted by immunotherapy. Based on this, we curate the treatment. And apart from that, the personalization per se for the breast cancer in the early stage, when I divide to early and metastatic, I'm right now talking about the early stage. Definitely, genetic testing is going to add a quite a bit. Not just olaparib, like just Dr. Shyam mentioned, the olaparib, like we can add on the treatment. But usually, if the patient got a BRCA positivity, they do have most of them the triple negative breast cancer. Recently the data has come like very strongly for the triple negative breast cancer to add more agents to have a better benefit, because the triple negative breast cancer what we are dealing with, the outcome is not so great. If any patient got a genetic abnormality like BRCA positivity, they do respond to simple chemotherapy regimens very well. No need to add on immunotherapy, no need to add an extra agent called as carboplatin to that. They do have a really good response. All the trials have shown if the patient have genetic abnormality, they do respond to chemotherapy simple regimen very well. So in that way, we will curate the regimen for the patient person. For number one, depending on the type of the cancer. Number two, any genetic abnormality underlying a person is having. So depending on this, early treatment of the cancer will be curated, that chemotherapy part. When coming to the surgery part, the personalization will happen most of the times based on the genetic abnormalities there are not. If genetic abnormality is positive, the BRCA positivity, we try to offer risk reducing surgery for the opposite breast. The same breast conservation we may not suggest like what we are suggesting like for other patients. Even though it's an early lump, we try to counsel them for removal of the entire breast as well as opposite breast if patient is willing to get it done. But majority of the patients do differ like with the whatever we counsel. So this is the curated approach what we see for the early breast cancer. Coming to the metastatic breast cancer, yes, lot of personalization will happen. And just like I mentioned before, ERPR HER2, if it is triple negative, we try to see PD-L1 also, some other marker where we can see to add on immunotherapy or not. And apart from that, in even as the time passes, we try to see any additional genetic abnormality, we can act on it. Already other panel speakers mentioned regarding PIK3 positive. For hormone positive, as a second line, we try to, if it is positive, we try to add on other line. Any metastatic cancer, we try to see any driver, just like the car is driven by a driver. The cancer cell, if you think as a car, it is driven by one driver, one mutation, one gene abnormality most of the times. If we act on it, we'll have a better response. In breast cancer, ERPR HER2 is a foundation to treat any cancer, but these drivers, if ever anything is like seen apart from these three, definitely we add on that benefit to have a better outcome. It's just one after the other sequencing. One, if one fails, we introduce the second one to have a better outcome. So one after the other in metastatic breast cancer, we try to introduce to improvise the outcome of the person. So this is the holistic personalized approach in a breast cancer.
Thank you, Dr. Kripa. Dr. Vaibhav, my next question will be for you. How do you feel are some challenges or limitations that exist in implementing personalized medicine, and how do researchers and clinicians address them, or around something like, please?
Yeah, actually, tumor is the biggest challenge. Tumor is comprised of our own body cells which have gone rogue, and they actually try to avoid whatever insult we inflict upon them, either via hormone therapy, target therapy, or chemotherapy. So, this mechanism of resistance, which eventually occurs after every therapy, is the biggest challenge from the tumor point of view. And to target that, actually, we have to be one step ahead of the tumor, one step ahead of the cancer. Luckily, in breast cancer scenario, we have got so many drugs because it's quite an disease which is the commonest amongst the world in females. So there are a lot of research, extensive research has gone on, and we have so many options. Now it's that's why for the same drug cannot be just given to a young female who is around 25-30 years age versus a lady who has got breast cancer at the extremes of life, maybe say 85 years. So that personalization is a basic job of medical oncologist to basically see what fits not only the tumor, the type of tumor. We have to study basic ER, PR, HER2, even PDL1 also in stage 4 has to be done in almost all the cases. Second will be the patient characteristic, the comorbidities, the diabetes, weight, as well as cachexia, performance status, whatever cardiac comorbidities. Sometimes in HER2 positive cancers, patient might have cardiac comorbidity. So the drugs which target that basically are cardiotoxic. So there you have to improvise. So basically you have to take in at least 10 different factors before tailoring a plan, before making a personalized plan. It takes a lot of effort. Plus, it takes a lot of counseling for the patient to understand. As India, people actually often correlate. They relate, okay, my cousin got this cancer, she was given a hormone therapy tablet, why am I being given chemo? These are routine questions which all of us face in our clinic. But then we have to tell them that every cancer is different, and and every individual is also different. So then we have to, in the light of the data which we have right now, we are basically guided by data, and whatever is best fit, we have to fit in for you according to your general condition and your tumor characteristic. So these two things are there. On top of that, the biggest thing in India, which actually most of our patients are paying from their pocket. So the finances also come into the picture sooner or later in this horizon as well. Earlier, treating a stage 4 breast cancer, patients obviously have financial challenges as well. So to fit a plan according to that, also needs to be considered, not mixing logistics with science, but that both of them can go hand in hand to make the perfect plan for the patient. So all this, covering all these aspects, we have to basically make a plan and then stick to it, because all said and done, the drugs are few and effective drugs are even few, because no chemotherapy, target therapy, immunotherapy, however costly it might be, nothing has a response rate of 100%. There is no guarantee over here that the drug which I will give will work. There are chances, there are odds, some 30-40% chances that the drug might not work. And as we move further in journey, that the lack of response keeps on growing. So at that time, you have to basically study the tumor as well. Sometimes for a precision oncology, you have to basically look into the biopsy of fresh tumor biopsy to see whether a new mutation has taken place. Has the tumor changed character because of some druggable, targetable mutation? You have to do that. Though the work, as Dr. Shyam also told you, that it's only 5 to 10% of the times we might be lucky enough to find such a mutation, but still, that 5% of the patients will definitely benefit. So these are the things for personalization and precision.
Thank you, Dr. Vaibhav. With this, I'd like to ask one question to Dr. Chanchal. Uh, as healthcare professionals, as healthcare providers, as the clinicians, how do you feel can doctors work together, or maybe work together with the communities to dispel some common myths or misconceptions that we have, and encourage patients to have a more proactive healthcare practice towards generally every type of ailment, and breast cancer particularly? Please, Dr. Chanchal.
I think the most important thing is involvement of the print and the electronic media to educate the people. Look into and get into survivor groups. I think there are a lot of survivorship programs everywhere in the country. All tertiary hospital has some sort of a survivorship program. I think these survivor groups should be taken into account, and through them, I think you can educate the general public at large, because uh, whatever we say to the public will have much more impact when a survivor comes out and says that. So that's an important aspect. So you need to reach out to the people at large, either through print and or through electronic media. I think social media is a very strong platform these days. Instead of spreading rumors in social media, I think these are the things which should go out in social media. There are so many ways. Most of the hospital have some social media activities, Facebook Live, and so on and so forth. So I think this should be taken care of, and all sorts of cancer awareness program should be used. And I think the other thing, along with this, all patient groups should be educated about medical insurance. Medical insurance is a very neglected aspect of medical therapy. I think what we have been talking about all through all this last an hour or so are all expensive affair. Every genetic testing, every targeted therapy, every personalized therapy doesn't come for free. There are no free lunches. So all things are expensive, and unless and until the patient has a medical insurance or is from the reimbursable category, it would be very difficult at the end of the day. No matter whatever we plan as a group of consultants, we will not be able to implement it if the patient cannot afford the drugs. So I think these are most important. Apart from the awareness of the disease, the so on and so forth, correcting the myths, I think awareness about getting medical insurance and how to provide for treatment. There are cancer specific medical insurance as well, which can be taken early in life and which can help them combat the disease. Whatever we do as a group of clinicians to combat the disease will only have the best of results if the patient can afford the drugs and take the drugs. So I think,
Right.
and also as I think Pankaj or Vaibhav, somebody was saying, making people aware of clinical trials, because that's an important aspect. Whatever we are uh, enjoying today is because of some results of clinical trial in the previous years. So that has to be understood. So I think these are the way forward when we take this platform further deep into the general population.
Thank you. Thank you, Dr. Chanchal. So with this, we'll come to the last segment of this discussion where I'll be going one by one. So Dr. Pankaj, I'll start with you. Your last key take-home message on this Breast Cancer Awareness Month and this auspicious occasion that we're discussing about breast cancer and creating awareness, please.
So, only thing I want to emphasize is please have faith on modern medicine, because if I'm getting 10 new patients, out of them 2 3 either have wasted 2 3 months or maybe a year. So the patient has initially had a small lump, so patient started having ulceration in the breast, till the patient had that faith in that traditional medication whatever the patient is getting. And the logic which is given to these patients is that this is the tumor which was inside and it has come outside. So I don't know how people buy that logic. And they come to us at times when they are in really bad shape, fungating breast mass, stage 4, multiple bone mets. So when we are talking about all this modern medicine, important is at least they should initiate and get themselves treated, investigated at a local hospital, even if it is a small hospital. At least they should be on the right way rather than going for these, you know, I should not name, but the traditional medication systems.
Thank you, Dr. Pankaj. Dr. Kripa, your take-home message to everyone who's watching our episode, be it a patient, be it a survivor, be it a caregiver or a family, please.
So, for patient especially, I would like to say all women, please examine the breast. Self-examination is the best way to detect by yourself. So, there are a lot of videos are right now available in YouTube to see the. Please see the self breast examination videos. Especially women, if they're feeling any lump, any new growth, any sudden onset of the lump, please do consult a physician nearby. And if it is suspicious, please don't go for lumpectomies. I do see a very quite a few cases who are undergoing lumpectomy. Please don't get your lump removal done. Just do the biopsy and scanning first. If ever is there, please do consult a oncologist. If any lump you're feeling, please try to reach out to proper tertiary care center and don't get treated with a gynecologist or general surgeon just like that. And please be aware of your body as well as breast your symptoms. And second thing, I would like to tell you, please do exercise as well as maintain healthy lifestyle habits and do create awareness amongst your women groups. And if ever any family strong family history is there in your family regarding the cancers, please consult a nearby tertiary cancer care center for help. It's always prevention. It's not the cure is the only solution in the society. If ever any strong family history is there, now things are progressing so well that we can prevent the occurrence of a cancer in a person who are lodging a risk genetic predisposition to cancer. Risk gene is there if ever they have. We can prevent the occurrence of cancer in them with the various modalities of surgery or screening. We can detect it very early. So please use your tertiary cancer care services and get a better health in the whole family.
Thank you, Dr. Kripa, for that wonderful message. Dr. Chanchal, I'll be pointing the mic towards you. Your take-home message for everyone who's watching on this occasion of breast cancer awareness, please.
I think breast cancer is one of the most treatable cancers, and it has a very good outcome. And early breast cancer is highly curable. So keep a dictum in mind. If your breast cancer is diagnosed early, your treatment is the shortest, your treatment cost is the minimal, and your outcome is the best. If your disease is diagnosed late, your treatment is never ending, your cost is enormous, and your outcome is poor. So keep that in mind. So the earlier you get detected and get treated by a specialist group of patients, of doctors, your chances are the best.
Right. Thank you, Dr. Chanchal. Dr. Vaibhav, before we close this session, your last take-home message for everyone, please.
Yeah, exactly. I concur that cancer is curable if detected early. So we have standard guidelines that after at least age of 45 years, every female should undergo screening mammogram once a year to detect this cancer early. That is the biggest tool which has actually increased the cure rates by detecting it early. Unfortunately, if you get it in an advanced stage or somehow it manages to go to stage 4, then also don't lose heart. Don't lose heart, because through molecular and precision and personalized care, now this stage 4 cancer has been converted into a chronic disease, just like a hypertension or a diabetes. I agree, you need to take treatment lifelong, but now we have got simpler treatments with lesser side effects, and the life expectancy is in years. In years, it's no, we are not talking days or months. So don't get disheartened, depressed once you have been told that you have stage 4 breast cancer. It is just that you have one more chronic disease to basically bother about and treat it. And we have got wonderful drugs. Science is progressing. As of now, we say stage 4 is incurable, but in other cancers like lung, melanoma, renal cell, through immunotherapy, part of these breast cancers, these stage 4 cancers are being cured. In breast also, similar stories unfolding. Let's hope for a brighter future even for stage 4.
Thank you. Thank you, Dr. Vaibhav. With this, I'd like to bring this particular panel to a closure. Firstly, I'd like to thank Pfizer for powering. Most importantly, I'd like to thank my panelists, Dr. Chanchal, Dr. Vaibhav, Dr. Pankaj, Dr. Kripa, and Dr. Shyam, who obviously told that he'll be leaving soon. Thank you. Thank you to each one of you for sparing the time out and helping Voice of Healthcare educate the audience about breast cancer. And lastly, thank you for the to the audience who has participated, who has engaged with us. Thank you, gentlemen and ladies, and thank you. Have a good evening.
Thank you all. Thank you.